Hi, and welcome to the National Day of Racial Healing for the Oral Health Community. I'm Annalise Cothran, the Executive Director of the American Institute of Dental Public Health. And on behalf of AIDPH, Open, and APHA Oral Health, thank you so much for being here today. We wanted to start off with a few housekeeping tips before we enter our conversation. So this workshop is divided into two parts. The first half will feature a panel discussion, followed by small group breakout sessions in the second half. We ask that for the first half, you go ahead and turn your cameras off, and then during the second half, keep them on. If you're looking for continuing education credit for this event, we will send an email at the end, and you must attend the entire hour and a half in order to earn 1.5 continuing education hours, and partial credit cannot be awarded. We also ask that everyone remain muted during the first half of the presentation. Lastly, we are recording the presentation and will make it available on our YouTube channel, but we will not be recording the small group discussions. I'm not going to read through this, but this is the information for continuing education credits. I will post the link into the chat that is linked to the AIDPH event where you can read this. This was also provided in advance. But I will quickly read the learning objectives for today, which is to evaluate systemic influences that both facilitate and impede oral health equity, to understand the impact of racial inequity within the oral health community, and then to explore opportunities for applying a lens of racial healing for both personal and professional work within oral health. No presenters have any conflicts of interest. And so today we are joined by Dr. Caswell Evans, and unfortunately Dr. Treadwell had a last-minute emergency, and so today we will be joined by Ms. Ife Johnson talking about racial equity and healing in the oral health community. So I'm going to briefly introduce Dr. Evans, who is the Associate Dean Emeritus for Prevention and Public Health Sciences at the University of Illinois Chicago College of Dentistry and former faculty at the UIC School of Public Health. He has served as the Executive Editor and Project Director for Oral Health in America, a report of the Surgeon General. He is also one of the founding board members of AIDPH. So we're so thrilled to have him joined here today. Ms. Ife Johnson is the Executive Director of the Oral Health Progress and Equity Network, and so she will also be joining us for this conversation. Thank you both for being here. I thought it may be helpful for us to do a little bit of level setting and context around racial healing. And so I thought we could, this quote was pulled directly from the Kellogg Foundation materials around racial healing, and it provides a really in-depth understanding of what racial healing is and how we can move forward with it. Racial healing recognizes the need to acknowledge and tell the truth about past wrongs created by individual and systemic racism and address the present consequences. It is a process and tool that can facilitate trust and build authentic relationships that bridge divides created by real and perceived differences. We believe it is essential to pursue racial healing prior to doing change-making work in a community, because before you can transform systems and structures, you must do the people work first. So I certainly appreciate Dr. Evans and Ms. Johnson for being here today and helping us do the people work first. So on that note, I'd like to start the conversation with the both of you and ask, from your perspectives and lived experiences, what is the current landscape of both systemic racism and racial healing in the US, and specifically as it relates to the oral health community? Dr. Evans, why don't we go with you first?
Thank you very much. Thank you for the invitation to participate. Um, we are living in an extraordinary period of time where the legacy and the presence of racism at an individual and a group and systems level that has been with us for centuries has surfaced, and it's been given an open-armed reception by a large portion of the United States population. It's been given an open-armed reception politically, and it has surfaced in its most evident and corrosive manner that exceeds anything that any of us have seen in our lifetimes. Historically, we know how racism has affected us all. I can remember, as someone who at the time was the age of Emmett Till and how he was slaughtered in the South for a transgression, perceived transgression that wasn't fully understood at the time. And I remember putting myself in his place, not saying that I would have done whatever he did, but noting that I was of the same age and I was in and out of the South going to North Carolina with my father at the time. And recognize that that could conceivably have been me. And even though when I would go to the South at that time, I saw the colored and white only drinking fountains and restrooms. But what we're seeing today far exceeds even those images. I think what we saw 2 weeks ago in the Capitol brought it home in very clear vision. So the good news is that while things are on the surface, it's sort of like bass fishing. When bass are on the surface, you've got a good time throwing poppers out there and dealing with them. So we have an issue that's now on the surface. And if this is not the time to try to address racism and racial healing, there's not going to be ever a better time. And I think we have the population, I think we have the profession, I think we have the opportunity to have some frank discussions and make some progress. And in having the frank discussions, we will have to admit some frailties on an individual basis and a systems basis. We will need to point to things that need to be changed and be optimistic that we can make the changes that that we're able to make. So I would just use that as my opening comment. I would look forward to Ms. Johnson's comment, and then we can get on to further discussion. So Ms. Johnson.
Thank you, Dr. Caswell. I also had opportunities to spend quite a bit of my lifetime in the South, and in the North. And I discovered what my father used to tell me, that there really is only down South and up South. Mm-hmm. And that in some ways down South would have their problems solved before up South realized they had them. And part of our issue, I think, as a nation is that we have failed to see the ugly underbelly of what's actually supporting our society. And it's, it's not capitalism, it's not democracy. In so many ways, a lot of our society was built originally on racism. And the idea of developing the concept of race was an economic engine around which most of our country developed. And we also have purposefully undereducated our population. We talk about how we have American exceptionalism and how great our systems are. But I think probably I was one of the last group of students that actually had civics taught in the school. And so if you no longer teach people about the system of government that they're under, it's very easy to co-opt them. And I think part of what we saw this past week in the Capitol was the result of people not understanding how government even works, not understanding what racism does to them, not for them. And one of my huge concerns this year has been, how do we help everyone understand and see the cost of racism? It has a very individualized cost to each of us. It's not just people of color that are impacted negatively, but our entire society. And having the ability to have that very open, frank, and honest conversation, which is hard to have, in some cases. Sometimes we have to have that discomfort, but discomfort is actually a good sign. As I used to like to say, if you get into a very cushy couch and you're comfortable there, you don't move. But when the spring pops out from underneath you, you get uncomfortable and you make a change. And I think that's where we are right now. We're at that, actually we've been blessed with this time period to have been isolated enough where we can't go out and avoid looking at what's staring us in the face. We have to see what's in front of us. We have to deal with the pandemic, as I think Dr. Christopher put it well, the pandemic of both COVID and racism, and that we have to find the vaccine for both. And this is that opportunity for us in ways that we probably have never had before, to have those open and honest conversations about what we can do together. With that, I'll turn it back over to you, Anna.
Right. No, those are great comments. Your reference to vaccine, I think, takes us in the direction of talking about health and talking about oral health. And, the terms we use and the systems that we have developed all have consequences. Some of them have intent. Others are just consequential. But I begin to think more and more that we've moved from the terminology of disparities. We're now talking about inequities, which are more intentional in terms of their outcome. Disparities more or less implies that these are just happenstantial differences. Inequities suggest that there are systems at play that create differences that are part of what we call inequities. But perhaps we should be looking at these more closely through the lens of racism. Are these inequities, in fact, the result of system and social, and as you mentioned, Ms. Johnson, educational and employment racism that have played out over generations? And so we're looking today, when we see even in our research, and we talk about inequities, are we really talking about racism and the effect of racism on health? As we look at the demographic data, as we look at our national reports, are these truly just inequities that have systems of causation that result in these differences? But are those systems of causations also charged substantially by essential racism? So that's one question I think we ought to consider. The other thing is, and we've had some recent discussions on this, even involving Annalise and the American Institute of Dental Public Health. We have systems that we rely upon, and are we holding those systems fully accountable for their racial impact and significance? And I'll lay out one that we're talking more and more about now. The Commission on Dental Accreditation, CODA, is responsible for establishing the standards in dental education, dental hygiene education, dental assisting education, you name it. If it's in dental and education, it's under CODA. CODA has a standard for dental school accreditation that focuses upon demographic diversity among students and among faculty. And their accreditation depends upon demonstrating that type of diversity. Now, we know among us what diversity should mean in a demographic sense, but I will state that schools pass if you've got a group of students wearing blue socks and a group of students wearing brown socks, and you've got a group of students wearing gray socks. That's diversity. We know that there are dental schools that have little or no students of color. We know that there are dental schools that have few, if any, faculty of color. Yet, CODA passes them all on this diversity standard. So do we have mechanisms within our own portfolio that we have not been strident enough holding those accountable to demonstrate and stand up to these expectations that they've established for themselves that have an impact upon the profession? That impact is a faculty impact. Are there enough faculty of color? And a student impact of bringing more diversity into the profession, be that dentistry, dental hygiene, what have you. So I lay those out. You know, are we looking at inequities from a racial lens, and are we holding systems that we have in place fully accountable relative to the doors that they have, the doors that they've opened and the standards they've set for themselves? Are we holding them accountable for those standards?
Yeah, Dr. Evans, I agree. And Ms. Johnson, what do you think? Are we holding everyone accountable? Are we really pushing systems change from the perspective of racial healing?
Well, I'd like to go back a little bit to the importance of language. We talk about diversity, and I'm not sure that's really what we mean sometimes when we talk about diversity. We haven't quite defined our terms yet. Folks who know me well know I have a problem with the word diversity because it means that we're divergent from something. So what is the standard from which we're diverting from? Rather than what I like to refer to as recognized normality. But perhaps it's not the question of diversity that we need to be addressing, but the question of equity that we need to talk about, and placing it in terms that are measurable and within a time frame. I think part of the issue that we are facing is that we have not codified what we're trying to achieve. If we can say that schools should have a 30% rate of enrollment for people of color by June of 2022 or 23 or whatever, then we actually have something that's measurable that we can say we've obtained it or we haven't. It's something where everyone can agree on what the goal is and we can move towards it. When we say we're going for it to be diverse, what do we mean? We have, there's people like Dr. Caswell said, you know, this is somebody who owns birds as opposed to someone who has fish for pets. You know, what is it that we are diverting from? But equity says that we're all having what we need to have an opportunity to have the same kinds of chances. And I don't think we really are using the language that we need to use to reach the goals that we want to have. And I think this is an opportunity for all of us in this call and in this group and in this field to say, what do we see as an equitable outcome for oral health? And we tend to generalize it a bit too much. I think we need to be sitting down and saying, you know, by 2025, we want to make sure that young Black children in Alabama are getting X number of visits to the dentist, or, you know, that we have enlisted X number of people to go out to do telehealth in their areas, or, you know, these kind of things. We just don't, we aren't addressing the specifics of what we're trying to achieve for equity. And therefore we leave the folks who really don't want it to necessarily happen and out. And we need to close those doors. You know, I think at this point, we have to start by also looking at what the system maintains. What have we allowed the system to build around the traditional group that has been the beneficiaries of systemic racism? Have we, I think, Dr. Evans, I think I heard you say this a few months ago, and it really resonated for me, that, that dental health is actually designed for the folks who have the most and who need it the least. And the folks who have the least and need it the most are left out of that system. How do we start there with that premise and say, how do we change our language so that we're addressing measurable goals to make that shift? And in making that shift, start dismantling the systemic racism that held it in place.
Okay. Yeah, that's an excellent comment. You know, we have a system in oral health that is a real challenge. We don't, if you look at our educational platform, we don't teach oral health really in schools of dentistry. We teach procedures. Very fewer schools, although they're expected to, make the connection that those procedures should have some sort of bearing on oral health. So that's one challenge. We don't teach, as you mentioned earlier, we don't teach the civics, if you want to call it that, of oral health. We have a system where dentists and I guess dental hygienists are the only ones licensed. We now have dental therapists, a few, that have an exclusive monopoly on, professional monopoly on providing this service to the public. However, the public aspect of oral health is often neglected, hardly mentioned, and perhaps weakly presented when it's presented in most dental schools. What we produce are people who are in private practice primarily, and that platform's beginning to change, but they have a private business. They are private entrepreneurs. They used to call themselves a cottage industry. which I thought was a rather insulting term for them to use on themselves back then, but you still see that every now and then. So it's every person for themselves with their little financial empire of providing dental procedures to people. And from a business perspective, they establish themselves in an area where that business is going to thrive. So from a capitalistic perspective, it's hard to argue with that, but what is lost in the process is any sense as to whether that business has an obligation in the public domain to ensure that all people in fact have access to care. And as you mentioned, Ms. Johnson, as I've been saying more and more, we have this conundrum of the proportion of the population that is comparatively least in need of care receives the most care. The portion of the population that is comparatively most in need of care receives the least care. And there's really no particular incentive other than recognizing the racism and the racial impact that results in. There's no particular influence on an individual dentist to step forward and say, I need to do more, or position their practice to say, if I set my practice up here, I can have a greater public health and social impact than if I set my practice up there. It happens that when they set their practice up there, it's perhaps financially more lucrative than if they set their practice up in another area. So we have some serious challenges that I think we have to look to dental education to do a better job starting there. And I think we also perhaps have to do a better job of recruiting dentists. Going back to your civics lesson, people who come into the profession understanding that not only do they have, and again, this is changing because more and more dentists are going into systems of care, and many of those systems are more responsive to the public need. But dentists who understand themselves as not private practitioners, but public servants who are in private practice, but they have an obligation to the public. And this, just to extend it, this is particularly true of those students that graduate from publicly funded dental schools. Now, admittedly, there are probably more publicly harassed dental schools now than supported, but these are public schools, they're not private schools. And even in the public school, this notion of making a public commitment to your professional service is often just unaddressed or addressed ineffectively.
Dr. Evans, I'm also curious to get your vantage point. We're getting ready to come into a new administration, new possibilities, some things that we have not seen as possibilities for quite a while right now. This group, the folks that are on this call, are the soldiers, the foot soldiers that can actually go out and make a difference in this coming year. What do you think we can do, given that this new administration is starting to look now at health equity? They're starting to look more into how oral health can have impact. And they're actually bringing oral health into the discussion about health in new ways. How do we help make sure that that doesn't fall by the wayside? How do we have the undergirding that's necessary to move this force forward?
Well, that's a great question. As I said before, you know, we've had some just horrific recent experience, but out of that have come some opportunities. I think the really utter failure of public health to respond to the COVID-19 pandemic due to restrictions that were imposed upon them politically. But I think it's going to have to resurrect a very serious discussion of what is public health, what is meant by the health of the public, and how do we all do a better job in that regard. The CDC has been unfortunately greatly tarnished in this whole situation. Dr. Redfield has capitulated in his leadership position. But it's going to open an opportunity to talk about public health in a way that we've not had that in the past. In the past, public health has always been kind of in the shadows and in the background, and now it's on the front page of newspapers as to what public health is about. And this presents a great opportunity for oral health to step forward, to sit at the table, and to present the values and the necessity of oral health in these discussions. Whereas in the past, we've been taking opportunities to knock on the door and hope to get invited, and sometimes squeeze across the threshold and get at the table. I think we'll have opportunities now to more boldly insert ourselves into these discussions. And I'm hoping that dentists and dentistry will be more actively involved in this massive surge of vaccination for COVID-19. You know, in the past, there has been kind of lip service to those roles, and not much has happened. But this is a great opportunity for dentistry to step forward in a national spotlight and be very active. So, you know, I don't, that's short of any specific answers, but I think we have a general opportunity to insert oral health more boldly into the public health discussion that I think must necessarily arise from the political and the pandemic that we're facing. So we've got both the political opportunity and the pandemic opportunity to insert oral health into the discussion.
Okay, and looking, we're getting close to time, but one of the things that I love that you said, you talked about us moving more boldly. I think that's a very important word for us to use this year, making sure that oral health is very boldly inserted into the importance of overall health, that as dentists are exposed to COVID, probably more so than any other group of physicians, that we also place ourselves in a position to say that we are also able to assist with changes in overall health. That step into the COVID space will be important for us this year. I really believe that. And before we close out, I also just wanted to touch on some of your perspectives on the impact of implicit bias in healthcare, especially in oral health. What impact do you feel that sometimes we don't really talk about implicit bias, you know, the impact versus the intent? You know, a lot of people are very good-hearted, but can unintentionally have negative impacts on some of the folks who, because of their expectations in the dental office or some of their experiences in the dental office, avoid going now because of implicit biases and whatnot. How do we help root those out and help make ourselves more aware of where those things are hiding, and how we can address them to start making oral health something that more people want to seek out?
Yeah. Well, the implicit bias is really a sneaky one, because that's the kind of thing that can just kind of creep up on you unexpectedly. You're unprepared for it, yet it's there. You know, I think we start with, we have to admit, if we think about, again, this private practice structure primarily of our profession, although again, that's changing pretty rapidly. We have to admit that there are practices that don't want those people in our waiting room. We start there. There are practices based upon a phone call for making an appointment. Certain cues are given, and that appointment is either not available or, it's only available 6 months down the line, or there is a harsh and impersonal response. So, implicit bias can be very subtle, and it's very difficult to address. But I think it gets back to what we talked about before. What are the civics of our profession? Do we see ourselves as, do we recognize the privilege of being the only ones licensed to provide this service to the entire public? And do we see that privilege as having therefore a responsibility to ensure that the public in all of its dimensions is welcomed into our practice settings? And we know that that's not the case. So I don't really have a formula, a short-term formula for implicit bias, but I think it, again, depends substantially on how we educate our workforce and how we select those who are chosen to enter the workforce. And, there's roles to play for dental organizations in terms of the messaging that they give out to their members. Some dental organizations are very quiet on this subject, and others are more expressive on this subject. So what are our dental organizations, what's their messaging to their membership in terms of the necessary roles that they can play and what kind of changes they should be making?
Thank you, Dr. Evans.
Mm-hmm.
This is a huge subject to try and cover in just a few minutes.
Mm-hmm.
And we know that we won't come up with the answer today, but we're making a step in the right direction.
Yeah.
And all the folks on this call are part of the solution. And so we'll be going back to you as participants on this call to help us come up and formulate our next steps and to explore how a day of racial healing can affect oral health. And with that, I want to thank Dr. Evans for, as always, bringing his wisdom to the room, and thank all of you for the wisdom that you're about to bring to the room. Thank you so much, Paul. And thank you all for your comments and participation today. Let me close out the day by saying that changing the course of a river is really hard work, especially when we've all been dumped into that river and the current is just sweeping us along. But we know it can be done. We've seen nature alter the course of rivers over time in all kinds of ways. We've seen beavers build dams. We've seen the architectural marvels of man-made structures like Hoover Dam. And they all change the course, the speed, and the flow of rivers. And from our dinner table to our nation's capital, we've been swept along by the powerful current of racism. And although it may seem sometimes that it's easier to just kind of go with the flow, we all have to work hard to alter the current of this system that we find ourselves caught in, or else we'll be caught up in the undertow and find ourselves drowning in it. We're uniquely poised at this moment in time to make a difference and to face this challenge. We collectively are the right people for this moment. The systems of racism ultimately serve none of us, and ultimately we'll all drown in it unless we stem the tide. It's in our own best interest that we have to decide to join forces to make these changes, because none of us can do it alone. However, it requires each of us individually to make that decision and commit to change and to see each other as part of a unified force for transformation, to see each other as being different, unique, and valued. Nothing can be built from a single element. So thank you for bringing your unique and valued self and voice and perspective and energy to the table today. And with that in mind, a sign-on letter is being prepared that will challenge each of us to advance racial healing by addressing systemic racism as a public health issue, and to address individual, institutional, and systemic racism in our oral health education, programming, research, policies, and organizational structures. And this letter will start circulating around the end of the month. And so we're asking you to join us in transforming our world. And let me get in a plug. This is what OPEN, the Oral Health Progress and Equity Network, is designed to do. If you want to join us, go to communities.openoralhealth.org. You can join us for free. A lot of you are already members, and we thank you for being there. And Annalise, I'll turn it back over to you to talk about the evaluations and the CEs. And thanks for being part of our seminar today. Go in peace.
Just really briefly, because I feel like Ife just left us on a most wonderful, perfect note that I want to still think about and take this experience back with me, but you'll receive an email for continuing education credits. And with that, I just thank you all for being here and being willing to participate in this discussion.
Thank you much.